Awesome. Good morning, everyone. We are really excited today to have Dr. Carla Nester from Iowa present to us on C3 Glomerulopathy. Dr. Nester is the Jean Robillard Professor of Internal Medicine and Division Director of Pediatric Nephrology in the University of Iowa, the Stead Family Children's Hospital in Iowa City. She's quadruple boarded internal medicine and nephrology, peds and adults, I guess. And has got several NIH-funded studies with the translational research program focusing on the topic of today's discussion on rare complement-mediated kidney disease. With no further ado, Dr. Nester.
Thank you very much, and welcome to everyone for joining me. I will begin very quickly by sharing my disclosures. It's a requirement of my university, but it's also something you all should know because midway through my talk, I'm going to be talking about some of the agents that that we were in fact clinical trial investigators for. So it's important for you to understand what my biases might be. So we're going to tackle basically 4 specific objectives. They won't surprise you. They're the basics. We need to talk about the mechanism because that perhaps makes it easier for you to understand why we got to where we got, if you will, with not only the current approach to management, but also when we think about the future approach to management. And then I want to touch on briefly, if we get to future management, how are you going to manage it in your own practice? Because there's going to be some real world issues, I suspect. So first, let's talk about the burden of disease. And actually, the important part here is that C3 glomerulopathy should be specifically a chronic disease. It should not be one that comes for a year and then is completely gone, for instance. It should be chronic, persistent alternative pathway activation. And that was the definition that was created back in 2017 when it adopted its new name of C3 glomerulopathy. Some of you might remember it as MPGN2, for instance. End-stage kidney disease in up to 80% of children within 10 years and 30 to 50% of adults. Now, again, this is one particular cohort, or this is a collage of a couple of different cohorts. It actually may even be slightly different in some of the cohorts, but this is more or less a summary of that. What's important is that post-transplant, there can be histologic evidence of C3 deposition almost immediately. And the classic case I always offer to people is I have one of my patients who she developed a hematoma. We had to go in and evacuate the hematoma 4 days post-transplant. I said, while you're in there, can you get me some tissue? Sure enough, 4 days after the transplant, very significant C3 deposition, 3-4 plus deposition. She went 10 years with that transplant, never developed clinical disease. In fact, her demise was from something completely separate from her disease. However, there is a recent Columbia study, and I gave you that particular reference, that said that 89% of patients will develop histologic evidence within 2 years of diagnosis. That's a lot of patients. And interestingly, in that document, 1/3 of them had completely clinical marker free, i.e. they didn't have any evidence on their clinical biopsy that they in fact had clinical evidence of the disease. Sorry, I apologize. I have a background motion sensor for my lights. Generally, it's published that 50% of these patients will get clinical disease. So I hearken you back, though, to the Columbia data that says 50% get overt clinical disease, but we don't know yet whether only histologic disease will give you a shorter renal half-life in a transplant, or if you have to have the clinical disease to get the shorter renal half-life. Question for another day. We don't know the answer to that. So let's talk about some of the challenges of diagnosis, because if you have a new therapeutic, you have to be clear you're dealing with the correct diagnosis, right? So these are some of the challenges. We used to say that it needed to be isolated. In fact, even in the 2017 consensus document, we were leaning heavily on that. But over the intervening years, we've discovered absolutely it does not need to be isolated. It does need to be 2 orders of magnitude. So 4 plus C3, 2 plus IgG, or 1 plus IgG, that sort of thing. And ignore IgM. Your pathologist will tell you it's such a large molecule that it can get trapped because of the degree of proteinuria that these patients have. So kind of put that away when you're thinking about it, but don't be stuck on the idea of isolated. Then finally, you know, we used to call this MPGN2. Well, we stopped calling it MPGN2 because probably only less than half of the patients that really fit the diagnostic criteria of dysregulated underlying complement system, only about half of them actually had the MPGN pattern. In fact, because I do Med-Peds, about many of the children that when I initially see them, they have mesangial proliferative disease, not membranal proliferative disease. So again, don't be stuck on the fact that it has to be MPGN. In fact, you know, I'm campaigning myself to change IC-MPGN to ICGN because, again, I see children and adults with mesangial proliferative immune complex GN of the idiopathic type. So one of the critical aspects when you're addressing one of the challenges is this idea of you have to rule out post-infection. It absolutely is more frequent in children, but it is absolutely present in your adult diabetic patient or your patient who gets an infected, you know, lesion of some kind. And you do that really by definition, according to the consensus statement, you do that by watching that C3. So if your patient presents with a low C3, if it goes normal at 12 weeks, that frankly was from the pediatric literature, but it's more or less the truth in adults also. And I can share with you some unpublished literature that a true C3G patient doesn't normalize their C3 within a year of diagnosis. So if you do it within 12 weeks, keep in the back of your mind, you may have had a really difficult peri or post-infectious GN in front of you. The reason I need to bring that up is because you certainly don't want to put a patient on a long-term therapy if there's a chance that they don't need it. So keep that in mind. And then all you guys know this, but it comes up frequently. It's actually been published that you can tell a PIGN patient from a C3G patient by their humps. Not true. This also from the Columbia data, thank goodness for lots of things that they publish for us. They've said that C3G patients are equally likely to have subepithelial humps as a post-infectious GN patient. And then finally, I think this is important. There is this transition back and forth between C3G and immune complex GN. In the Columbia series where they talked about those humps, it was about 8% of patients. They might have a C3G diagnosis one time, they have an IC-MPGN or ICGN diagnosis the next time, or even back and forth. I've had patients that have gone back and forth. You might ask why. Well, we're guessing, but we think it's if a significant infection is triggering the current C3G exacerbation, it will be a classical pathway disease more likely because of the infection, if you will. So those patients very frequently have a lot more IG. You give them time to get away from their infection, they go back to just being a baseline C3G patient. There's no way to actually prove that, but that's the current thinking about how that happens. In our, I think I mentioned, in our database, it's actually 12% of patients actually do that. Then to pile on a little bit more confusion, there can be C3 deposition as you approach end-stage kidney disease. For instance, when you get worse and worse GFR, you begin accumulating some of the complement proteins, particularly factor D, which is the rate-limiting step of the alternative pathway. And so guess what? If you start accumulating factor D because you're frankly not filtering that out anymore, you can get some intrinsic activation of the complement system on the biopsy. Now, frankly, it shouldn't be 4+ C3 deposition, that sort of thing. But unfortunately, because it is local complement activation, it may be accounting for why in some of your FSGS patients with late stage disease, wow, where's that 1+, 2+ C3 coming from in that FSGS patient? Do they have FSGS and C3G? Probably not if they're late stage CKD. And then I mentioned FSGS, but C3 deposition is not uncommon in other non C3G biopsies. And by that, what I mean is these are patients that don't have underlying intrinsic complement dysregulation. So this is what I'm calling a non-C3G biopsy. And diabetic kidney disease is one of the perfect examples. Very frequently, and I mean, your pathologist knows when something is diabetic kidney disease, but there may be also quite a bit of C3 deposited. So you need to sort of put your thinking cap on and think about, okay, what am I really dealing with? Does my diabetic patient have an intercurrent infection or? We are really slow to assign diseases. I'm not saying that we are correct, but we are really slow to begin assigning, my patient has IgA and C3. My patient has diabetic kidney disease and C3 glomerulopathy. It's something to think about, that there can be ways, or there can be these other diseases where you can see C3 deposition, and it's probably not true underlying dysregulation. There may be, for some reason, some local activation or some even systemic activation if it's infection. And then finally, paraprotein-related disease, which I'm going to come back to in just a moment, but it does end up being one of the confounders in this setting and probably has a different therapeutic approach. So one more challenge I think that we face significantly, and it's actually around the nomenclature. So you may know this, or you may have seen this obviously in the literature, and you're wondering, why did they say it this way versus that way, et cetera, et cetera. There actually is an intent to having these three terminology, these three terms, if you will. C3 glomerulopathy is the actual disease. This is the one that was declared in the consensus statement to be chronic disease underlying dysregulation of the complement system, not activation, but dysregulation. Then, and that's, by the way, the reference for that, but then there is what your pathologist sees. So it's not unlike when your pathologist sees FSGS, you have to determine whether it's secondary FSGS or primary FSGS, right? I mean, obviously your pathologist sees some clues, et cetera, but it's somewhat like that in that your pathologist sees C3 dominant, not C3GN, but C3 dominant glomerulonephritis. And the glomerulonephritis piece is simply to say that it's proliferative. Mesangial proliferative, the basement membrane's proliferative, whatever it is, but that's what your pathologist sees. But if he or she says to you C3 dominant glomerulonephritis, you should not immediately jump to this is C3G, because it may not be, and you will make treatment errors if you do that automatically without sort of thinking that through. And then I already mentioned to you one of the ways you can sort of rule out the post-infectious piece. I wish we had better biomarkers. We could talk about factor B autoantibody, down the road a little bit, because that's been published that might help you, sort of thing. Anyway, C3 dominant glomerulonephritis is different than C3 glomerulonephritis, which is one of the flavors, if you will, of C3G. So there's DDD and C3 glomerulonephritis. Both of these are C3 dominant glomerulonephritides, if that makes sense. I don't want to belabor it much more than this, but the point is we maybe made some mistakes along the way choosing names that are potentially confusing people. So the challenges we face do cause some delays in diagnosis. Part of it is because it's so very rare. Part of it is because understanding what the diagnosis should look like or what the patient should look like, et cetera. But I thought that it was fair to share with you very quickly this survey that was done. This has been suspected by many that there were delays, but this survey is kind of fun. So it's 385 patients, and this is what the breakdown looks like across those 385 patients. And it's kind of fun because you'll see that time from symptom to onset, symptom onset to first consultation, and you can see the countries listed across the top, can be as many as 17.6 weeks. That's quite a time frame, right? And I've absolutely experienced, I have one patient I just met recently. She presented with really high blood pressure and proteinuria hematuria in her OB office. She then gets a referral to her primary care doctor, who she sees, but then the primary care doctors got to refer her to the nephrologist. So you can see there's quite a path for this young lady to actually get into the actual diagnosis, which may take another 13 weeks, for instance. So I think this is not anything any of us can do about with our given medical systems, frankly, except for increase our awareness of first of all, that delays occur. For instance, the other part of that was 10% of patients wait up to 5 months to get their diagnosis. And I will tell you, based on the general trajectory of loss of kidney function in the progressive group. Not everybody is super progressive, don't get me wrong, but in the progressive group, the loss of kidney function or the trajectory of the GFR decline is very significant. So 5 months is potentially important for this group of patients. And many of you may have even seen, I absolutely have seen patients present to me. Example, 8-year-old presented in October. She was at end stage by January, despite everything we could do for her. And she didn't present it in stage, you know what I mean? Her GFR was still okay, et cetera, but she was very rapidly progressive. That's not the norm, frankly, but you can see where 5 months might actually be a problem for patients. So what does the C3G patient look like? Well, first of all, this is unpublished data from Iowa, but it matches, for instance, the newly published RaDaR data out of the UK. The overall median age is 16. Again, I mentioned earlier that, it doesn't make any difference whether you're DDD or C3G, that you still have roughly a median age of that half and half male, female, essentially. The youngest patient that's actually been reported is 2 years of age, and that actually comes from the UK data. And you can see what their distribution is for the pediatric patient group. And again, this is particularly important, obviously, because these patients are generally in the category of multiple kidney loss, right? So they get transplants, it recurs, they get another transplant, it recurs. So having patients with a median age of 9 in that pediatric group can be a little bit daunting. Few other facts about how these patients present. They do not all present with low C3. In fact, you can have a flat out pathogenic gene mutation that is a type 2, meaning they've got plenty of C3 floating around and just half of it doesn't work, for instance. So, but the point is that many are low C3, so that helps you. They don't tend to be the really baseline low that post-infectious GN patients will be. I thought this would also be a little bit not surprising. The vast majority of them have blood in the urine because of the inflammation, because of the itis on biopsy, but not all. And then another point that's actually kind of important, particularly for those of you that are in rural states, because this happens actually rural medical settings, I should say. Many of these patients have pyuria. So what happens if your 19-year-old young lady presents to the emergency department with proteinuria, hematuria, and pyuria? What do? They put her on antibiotics and send her home and say she's got a UTI. If you don't, well, first of all, if you're not suspicious of the proteinuria, but if you don't do an albumin and recognize that albumin is only 2.1 in that 19-year-old, that never happens in UTI, right? So the point is that many of these patients have sterile pyuria. So keep that in mind when you're thinking about the patient. And then the median urine protein at presentation is at least that 3.3 grams. Many of you have seen 10 grams. In children, we see 25 grams, et cetera. So lots of urine protein in this group of patients. A couple of other features are going to revolve around actually the drivers of disease. And so this is the alternative pathway. I'll just share it with you very quickly. You start at C3, you move all the way down to the membrane attack complex. These are the important autoantibodies that we should talk about, the C5 and the C3 nephritic factor, just to show you where they are. But roughly, again, in the Iowa cohort, in the UK cohort, I believe they have 21% genetic abnormality. We have 17% genetic abnormality. Generally, they are in genes that are in this alternative pathway, C3, factor B, factor H, places in the alternative pathway that may actually cause an AP-mediated disease, if you will. But much, much more significant than the genetic abnormalities are the autoantibodies. So keep that in mind. We should remember that really this is overwhelmingly an autoimmune disease, not a genetic disease. And then let's do our quick discussion of the paraproteins. Generally speaking, you know this. I mean, this is more likely to be the case in the over 50-year-old. And in fact, KDIGO in 2021, I believe, said for all over 50-year-olds that if you develop C3G at or over the age of 50 for the first time, you absolutely should be going looking for the paraprotein. That's really the point here. They're clones. We're not exactly sure what they do. We are just recently ourselves digging into this very tightly. It's been published that they can act like nephritic factors. We're discovering in our cohort, which is not a large cohort, but in our cohort, maybe a quarter of them actually have factor H autoantibodies, relatively low titer, but why are they there? They may actually be causing disease in these patients. Why they're causing C3G instead of atypical aHUS, for instance. We don't know that exactly. We're still looking at it, but it may very well be where on the factor H protein are these autoantibodies targeting. You'll just have to wait to hear more about that from us. But the incidence rate, the reason KDIGO came through and said, you need to do this testing is the incidences ranges quite broadly, unfortunately, but 33 to 83%. So very, very possible that your older than 50-year-old has a paraprotein. Why look for it instead of just labeling them C3G and moving on? It's because there have been some decent data coming out of the French group that says that if you treat the paraprotein with an anti-B cell, an anti-clone drug, if you will, these patients actually have better renal outcomes, and I've given you a few references. We're going to have to reassess that once we have availability of complement inhibition, but I will forewarn you, I am still in favor of getting rid of the problem instead of just treating with a complement inhibitor. But we'll see how this all shakes out, if you will. So couple of slides on current recommendations, and we'll go through this rather quickly. You guys know this data. It's been out there for a little while, but it's not based on trial data. It was all retrospective. It was actually, frankly, based on more than anything how we were treating lupus patients. So that's how we got to the mycophenolate mofetil and the steroids in that group. But it starts with supportive cares, and at the time of this publication, it didn't include SGLT2 inhibitors or sparsentan, et cetera, et cetera. So we were talking ACE, ARB, weight control, et cetera. So then if your patient with that regimen still has over 1 gram of urine protein, it was suggested that you begin the mycophenolate mofetil and the steroids. I'm going to give you the data that we use to support that. Again, all cohort data, not clinical trial data. And then finally, if the mycophenolate mofetil and steroids are not effective, you can actually consider using eculizumab. I will tell you, in the room discussing this, we knew that it wasn't exactly the right approach, but we thought, okay, it was the only escalation of care we could think to actually do. We didn't consider rituximab, we didn't consider plasma exchange, et cetera. And I'll share just a little bit of transplant data as to why we didn't, but there you have it. We considered eculizumab. Why protein is a target? Many of you will know, because I heard that you just had John Barrett there not so long ago, many of you will know that we're really excited that we now have proteinuria as an official surrogate marker for that disease. It is not an official surrogate marker for C3G, but you can see from this figure, this is from the RaDaR data, the UK data, if you can get a lower protein, and they're doing the less than 0.88 grams per gram, you can get a better renal half-life versus if you've got that greater than 0.8 grams per gram, your renal half-life is not terribly good by their Kaplan-Meier. And then frankly, if you can get reductions in protein over a 12-month period, so again, this sounds or looks like this might be a pretty decent target for you, that you can actually get a reduced hazard ratio for getting renal, they use renal failure instead of ESKD. But the point is that lowering the urine protein does seem to limit your risk for getting damage to your kidney. So this is why we're using protein as a target. So what is the efficacy? So I've colorized this so you could see it quick at a glance, that basically if you have red is bad. Red is those that had zero response to mycophenolate mofetil and steroids. Blue are those that actually went right on to end stage. So you can see across, and these are not large cohorts at all. You know, the largest one's 42 patients, but in an ultra rare disease, that's not awful perhaps. But again, uncontrolled data. The response was highly variable across these cohorts. For instance, the Spanish cohort didn't do terribly bad. I mean, not perfect, but not terribly bad. The real point is that lots of kidney failure on current cares, about 30% globally appear to respond. And I will say that's essentially what I see too. So there, and I've absolutely had complete remission in a group of patients. So it is something for you to consider. How about eculizumab? I know this is a busy slide, so what I'm just going to share with you very quickly, these are the adult patients. There were 26 of them total. This is what they were on as far as treatment. This is steroids, mycophenolate and steroids, even plasma exchange, even cyclophosphamide, etc. 6 of 26 of the patients on eculizumab added to what they were on did have a complete response. Another 6 had partial response. So you can see that 12 of 26 did get additional benefit from the addition of eculizumab. An additional benefit may be improvement in urine protein, or it may have been improvement of GFR, or you can see a bunch of different things. So that is in fact what informed why KDIGO would have said consider a terminal complement blockade. By the way, probably not a big difference between whether you want to use ravulizumab or eculizumab. The response should be fairly similar. And oh, by the way, it didn't make a difference whether your C5b through 9 or SMAC were elevated as to whether you were going to be a responder or not. And that's important because we have had published literature that said you had to have the elevated MAC or you're looking at a non-responder. So this is the very quick transplant group I wanted to bring up because this is a meta-analysis. It's still kind of small, 122 patients, but you can see that these are patients who are on calcineurin inhibitor, on mycophenolate mofetil. Many of them are on steroids also. So they're already on double or triple therapy, and you're adding a fourth mechanism, whether you added eculizumab, therapeutic exchange, or rituximab. 33% of the patients lost their allograft despite that addition. 42% of the ones exposed to plasma exchange lost their allograft. And then finally, 81% lost their allograft despite rituximab. So, and we'll with this slide, we'll sort of think about what we might have been doing with those agents or with our mycophenolate mofetil and steroids. I've taken my pathway. You can see this. I've added some cells because the anaphytoxins will be drawing those cells to the kidney. So I just added you some cells to that kidney. If you use steroids and mycophenolate, in fact, you might be able to knock down your immune reaction to those anaphytoxins. You may also be able to knock down the B cells that are making those nephritic factors, or the T cell help that was making those nephritic factors, perhaps. If you add terminal complement blockade, you're going to knock down the C5a cells response, if you will, and you're going to knock down MAC, right? What you are not doing with either of these agents is stopping C3 deposition. Hopefully that makes sense to you. That is still happening regardless of what you're doing with either of these two agents. So it is really important that you recognize that, because that's a piece that you're going to miss. For instance, using either of these interventions, if your C3 is 12 and you call 90 normal, for instance, you are not going to normalize their C3 on these two agents. So that's important to keep in mind. So let's talk very quickly about the animal models that triggered, well, what are we going to do next? And so again, there's our pathway to think from. And just to give you background, we all use the factor H knockout mouse in our laboratory settings because that's the mouse model. Doesn't have atypical aHUS, it has C3GN on biopsy. So we all use that factor H knockout. What if you now also knock out C5? So this is a mouse that, you know, it would be the same as if you were going to give them terminal complement blockade, right? Turns out that you partially ameliorate their disease. So it turns out that there is some of C3GN that is likely to be terminal pathway mediated. We don't know how much, but there's likely to be some. What if you knock out factor B? That mouse model actually completely resolved their C3GN. Then I had to do a little bit of twisting and turning to bring this animal model to you. But let's say you knock out C3 or you incapacitate C3 in a rat model, you stop making breakdown products. In that rat model, now you are able to clear your basement membrane because you're no longer placing C3 deposits there. So this actually informs why we got to where we got with the actual next interventions, if you will. So this has been presented publicly, and I apologize, there's an extra light in my room from the sun, which I wasn't expecting wasn't coming up quite this early. So this has been presented publicly, so I've skinnied it down significantly. But first, let's these are in order of when they came to us as clinicians. So this one we started trialing in our setting in 2019 with the phase 2 factor B inhibition. It's an oral agent, 200 milligrams POBID. Used to be required to be in the refrigerator. Now it is not. It's a room temperature drug. This trial was greater than 18-year-old, native kidney disease. The phase 2 trial actually had their transplants in it. That was the one I was mentioning back in 2019. They did adolescent, they have an adolescent C3G phase ongoing. I was just hearing from you all that you all may have still this one ongoing in your country. Right now, we are actually closed in the US for the factor B inhibitor for C3G anyway, except for the adolescents. There is now also an adolescent and adult immune complex MPGN trial that's ongoing in our setting. And this is the poster, which just gives you some of the crucial pieces of this, because I want to make sure I give us time to talk about not only can you see these clinical improvements, but because I'm in a biomarker research setting, I want to share with you a little bit about what happens to the biomarkers. But again, randomized, controlled, placebo-controlled, 6-month study of placebo control. Then everybody moved into the next 6 months. Everybody was treated. That study, by the way, is still ongoing. So they're still monitoring patients for long-term efficacy and safety. I already gave you the age group, et cetera. They had a 35.1% reduction in the urine protein on top of mycophenolate mofetil and whatever they were using for baseline supportive care, whether that was ACE, ARB, et cetera. So they had a 35.1% reduction in the urine protein, of 43.5% improvement in those who actually achieved a composite renal endpoint. And again, that's a combination of both urine protein and stabilization of the GFR. One of the things that I think was quite fun in this one, it is very satisfying for me who practices pediatrics, is this idea of the eGFR trajectory. And so because I felt like I needed to share a little bit more about that, I'm showing you this figure, which was actually from the ASN talk. What they did is in an exploratory endpoint is they collected the GFR in the previous 2 years prior to actually being exposed to this, to the study drug, so the factor B inhibitor. And then, of course, they monitored the GFR. And you can see that there was a very substantial change in the trajectory of the GFR, which is something that we have not seen, period, in our population. So for me, this was a really exciting finding to see, because in any of these trials, they were not allowed to use complement biomarkers as a measure of efficacy. You all probably know that, but they're not legitimate surrogates for these diseases. But we, of course, you won't be surprised, have watched biomarkers throughout the entire process, but they were not allowed to use them for regulatory agencies. So it was very nice to see that you actually saw what looked to us like an improvement in the baseline disease. And then, of course, we have to present safety because, as you know, the major risk factor for all of the AP blockers, very much like the terminal pathway blockers, is this idea of encapsulated organisms. And in their study, I always think it's funny that even in the placebo group, they had some that were suspected to be related to the study medication. But they had one strep pneumonia infection in that group. That happened to be my patient. But not an excess of infections, if you will, in this group of patients. Now let's just skip right on to the next one. C3, C3b inhibition. This one is interesting because it's a subcutaneous infusion. It's the dose is approximately 1080 milligrams twice weekly. They deliver it themselves. This was studied in greater than 12-year-olds, native and transplant, C3G and immune complex MPGN. So the more comprehensive study. The other one is still, the other sponsor is still working through their study. Again, 6 months of placebo controlled. I already gave you the patient population. Again, they could have been on MMF. They could have been on ACE, ARB, et cetera. They had to be stable on whatever they were on, same as the prior study, for at least 12 weeks before they could come into study, but same background burden of medications, if you will. This group had a 67% improvement in the urine protein, also an improvement in the composite renal score, which was very similar. It was proteinuria reduction and stabilization of the GFR. You can see that they had a significant number of patients with a reduction in urine protein by 50%. But this is also a fun one. This is why I brought to you that rat model, that if you can block the C3, perhaps you can actually reduce the C3 deposition on the biopsy. So that's again, and again, I didn't mean to skip over that in the factor B inhibitor trial. They also saw, they just reported it out differently that so that it was a different way of reporting it, but this one was still in the percentage, if you will. So 74% reduction in the C3C. And then they also not quite as significantly had a change in the GFR trajectory for the patients. Because I added one of the more sponsor-related slide for the other agent to keep us well balanced here, I'm going to add one for the sponsor-related figure here, and I thought this one would be your most impressive one for you, and that's to just sort of suggest to you that no matter what your patient population was, pediatric, adult, C3G, ICGN, or transplant or native, you add a pretty impressive urine protein improvement. So you can see this drug also is going to be seen quite nicely, I think, in our future of treatment of this group of patients. In this study, by the way, it did have transplant. You had to, this is my editorial for you very quickly. You had to wait for 1 gram of urine protein in your transplant before they would be eligible for the trial. I would like to argue that maybe we shouldn't do that when we get to the real world, but again, we can talk about that. And then same picture I share with you for the adverse events, 0 encapsulated organism, encapsulated meningitis organisms, if you will. They had 1 case of pneumonia in this trial also. So very similar safety profile. You all may know that in the beginning, when we were thinking about these drugs, we started testing our first complement inhibitor back in 2011, not eculizumab. It was a drug called SCR1 by a company named Celldex. But anyway, we worried a little bit that all of our patients were going to get sick with encapsulated organisms in the effort to treat this disease. So this safety data, if it pans out over longer periods of time in the real world setting, which real world setting is always different than clinical trials, right? If it pans out in the real world setting, I think we're going to be pretty satisfied. So I promised you some biomarkers. So I've got one for each agent. This is a 22-year-old. He's had 3 recent admissions for nephrotic syndrome, and that generally means, admission because the swelling is completely out of control, may need IV diuretics, et cetera, et cetera. Anyway, 3 recent admissions for nephrotic syndrome. This happens to be what the moral, our clinical laboratory biomarkers look like, and you can see that what I'm hoping you're seeing is Not 90 or 0.9 is normal for the C3. This young man has a 0.2. He never had more than a 0.2 for the prior 4 years of his known diagnosis. Very low terminal pathway. You might remember that figure I shared with you, very low terminal pathway. He's using up complement products left and right and making MAC, right? So yes, you could put him on eculizumab and you would get rid of MAC. You would make the C5 go into the normal range. You would not do anything with the 0.2 C3, and you would not do anything with the fact that his disease is driven by nephritic factors, which is, again, the most likely cause. What if I now put this young man on factor B inhibition? This is what you get. His C3 goes into the normal range because now you're blocking the pathway at the AP, so he can no longer deposit C3 breakdown products. In theory, on his biopsy, he can no longer chew up C3 and make more membrane attack complex. And in fact, that's what you see. So this young man has been on drug now for a little over 3 years, or up to 3 years. No additional nephrotic syndrome episodes. His urine protein is completely normal. And interesting, I'm bringing this up because this is not thought about very frequently. His hemoglobin is completely normal. We've often thought that our patients have so much inflammation that the red cell half-life may be shorter, et cetera, et cetera. And in fact, he normally had a hemoglobin of 9 something in this 22-year-old male, completely normal right now. So I think that this would be considered what you would call a home run on factor B blockade. How about C3, C3b blockade? This young lady's a 12-year-old. She's on mycophenolate, and he was, by the way, on mycophenolate and steroids also. She's been on mycophenolate and steroids for 7 months before she joins the study. This is what her biomarkers look like. Yes, she's got that telltale anemia. Albumin's only 3.1. Urine protein is 7.6 grams. We consider 0.2 to be normal for us. C3, very low, 90. You can see 90 is normal. Factor 5 is used up. APFA, meaning the alternative pathway, now is practically not even working because there's not even enough C3 to make the pathway go. And, oh, by the way, very high C5b through 9 and very high nephritic factors. So we place her on pegcetacoplan, and this is what her biomarkers look like. Because we were blinded, we were not allowed to see the biomarkers in the first 6 months of the study. I was allowed to look at the biomarkers later, so we tested them at roughly 8 months, so well past her placebo phase, if you will. Hemoglobin is now 12.2, albumin completely normal at 4.5, UPC also completely normal at 0.175. C5 at 8 months on drug, we presume, we don't know, maybe she's only 2 months on drug, but C5, oh, by the way, this is a signature of pegcetacoplan patients. They get an ultra high C3. This is how I know my young patients are or are not being compliant, frankly, but they get a really high C3. Interestingly, she hasn't recovered her C5 yet, so maybe she is only on 2 months worth of drug. But this is really what I want to draw your attention to. Her APFA is now 0, not because she doesn't have C3 for the pathway, it's 0 because of the drug. So she flipped from 0 because of no C3 to now C3 that's now blocked by drug, if you will. But also importantly, these drugs, neither one of them will do anything about the nephritic factor. They're there. These are not anti-B cell drugs. These are not anti-plasma cell drugs. They're there, and we're just stuck with them until they're not there. So let's go through then I think I just have about 2 more slides. We'll go through what the landscape looks like. We've talked about ravulizumab, eculizumab, what they can potentially do to those of your patients that actually have terminal pathway portions of disease, but it will never be a full treatment for the vast majority of patients. What about C5a receptor? You may know avacopan was trialed in this, and it was just recently, it was actually trialed. It was the first one, one of the first ones anyway. It was actually trialed, did not work, just recently published, so you'll get to see that it didn't work in the C3G setting. You also may be aware that there were 2 factor D inhibitors. D is the rate limiting step. You need D to cleave B into its BB and BA portion. So it's an incredibly important protein. It just turns out that you have to block it so incredibly tightly in order to make it useful. Anyway, those two agents didn't work. You're aware that Omeris, I believe their MASP-3 inhibitor, MASP can cleave factor D, for instance. So that's why that might be useful. There's a newer agent that's, I actually didn't look recently if they're still in their phase 1, phase 2 portion. But then, of course, there's your C3 inhibitor and your factor B inhibitor. And then the newest one on the block is the Q32 drug that actually delivers factor H to the kidney. So in theory, if you do have excess complement activity at the level of the kidney, you can control it by that delivered drug. I don't know where we are on that one exactly right now. So I want to give you all plenty of time for questions. So I'm going to uncover all of these questions rather quickly. You'll have them for your recording. If you find out that AP blockade becomes available to you, we don't have them available yet. We hear a rumor, of course, that they're coming, or at least one of them may actually get approval soonish. We also heard that the EMA has approved one of them already, etc. These are the sorts of questions that you're going to need to sort through. How can we rule out those confounders faster, easier? How do we use our biomarkers to streamline things? How early is too early to start AP blockade? And if you start AP blockade, do you start it before or after your SGLT2 inhibitors, et cetera? What do you do in transplant? How are you going to protect these patients from infection? You know, I'm in a very rural state. Many of my patients are hours away from me. I can't have them 6 hours away in an emergency room with a fever and nobody paying attention to they're on a complement inhibitor, right? So you're going to have to set in place plans that are going to be important to you. And then finally, the million-dollar question: how are you going to choose which AP blocker you want to use if you get lucky enough to get both of them? And then before I go to that, I will take some time to take questions if I could.
Absolutely. Thank you for that really stellar overview of the topic. I mean, this is one lecture that I guess one has to take to understand C3G. So it's open for questions. Oh, there's a question from the conference room already.
Hi, thank you very much. This is David Massicott. I'm one of the GN nephrologists here. That was really, really fantastic. I agree. It was a great overview and nice presentation of very complement pathway, the alternate complement pathway. A question regarding the overlap between post-infectious and actual C3 glomerulopathy. We've seen quite a few patients that they get a biopsy that shows C3 dominant GN, and this occurs possibly in the setting of some infection. And things tend to get better as the infection resolves, but they tend to get these repeated bouts of kind of like the first case you presented, these repeated bouts of AKI and nephrotic syndrome, which tend to occur around an infection. And while, you know, you might think that these patients just have a post-infectious GN, and actually their numbers might normalize in between, it still makes me think that they have a dysregulated complement pathway, and there's something that's obviously triggering it, the infection, and they're getting these severe manifestations. And so are these patients that I'm guessing they were not, those types of patients would not have been included in the trials, but to me, these seem like the kind of patients that might benefit, although the infection is kind of triggering their flare, if you will. You know, perhaps giving the complement blockade will prevent them from flaring.
Yeah, you know, well, first of all, I'll be fair to say we don't know the answer to that, but I'll start with you're exactly right. The classic teaching is if they get over it, it's not C3G. But if you've got patients that are repeatedly getting episodes, also, by the way, the flip side of that coin is the classic teaching is post-infectious GN shouldn't recur, right? So if you do have recurrent episodes, you do have to wonder if there is some underlying risk for this happening. And particularly if you're losing GFR, each AKI you get or each nephrotic syndrome episode you get, I absolutely would be wondering if, when it's available to you, if you want to at least do a trial of an alternative pathway blocker. Now, obviously, those infections that trigger disease can't be encapsulated, right? But if they weren't encapsulated, and let's say you put the patient on one of the agents and you go a year or 2 or 3 years now with no episodes, then it would be it would certainly convince me that you've done something good for the patient, provided they don't run into any safety issues. It's not a small issue, you know, thinking about the safety issues, but you do have to wonder if every AKI or every new nephrotic syndrome episode is not taking away GFR points. We don't know the answer, but that's the sort of one of the questions we're going to need to answer in the future.
Thank you.
For sure. Todd?
Yeah, great. Thank you very much, Dr. Nester. I'll echo David and say that was an excellent overview. I work quite closely with David in our GN clinic. I could probably ask you questions for 20 minutes, but I'll maybe start with just a few. The first one is with respect to the biomarkers and testing. So we are a little bit limited in Ottawa, but also in Canada in general. I have sent samples to Iowa, and I think that it's probably one of the best places in the world to get testing done. But it's expensive, and it takes us probably 8 to 12 weeks to get those results back just because of funding issues. If you had to choose a few biomarkers that you think are essential in this condition, C3GN, what would you want to prioritize if we were limited in our funding? And I guess the question is, like, if they have the other one are the CNEFs, like, can we just look for a C3, or do we need to look for all of them?
Yeah, so it's a great question, and the best of all worlds, you know, it would be ideal. We learn a lot about our patients by getting the entire panel, but I completely understand, and you're not alone. So I guess in thinking about priority, I would be keen to look for the drivers of disease, and so I would sequence them in. If you've only got enough money, or you can only get C3 nephritic factor, I would get that one. That one's the most common. C5 nephritic factor is next, because there is a portion of patients, meaning are double positive, meaning C3 and C5. So if you get the C3, you're done. You don't even need to worry if you've got the C5. There are probably about 30% of patients that are C5 only. So by doing C3 nephs, you're going to potentially miss that portion of patients. But again, if you're thinking about funding, you might not do the C5 neph. And then frankly, the C4 neph is even more uncommon. For me, it tends to be in the younger patients, for instance. So I might, you know, pile that down a little bit lower. But in terms of thinking about biomarkers, if I've got a transplant patient in front of me who had a fairly difficult C3G course, I was clear it was C3G in the native kidney, it was rather progressive, I would do that patient's genetics, frankly, before I would put a kidney in, because one of the large risk factors for recurrence post-transplant is going to end up being you know, that pathogenic complement gene variant, for instance. And so that's kind of the sequence I would work for. I wouldn't automatically jump to BA or factor D. Those are elevated, and as worse your kidney function gets. I think MAX you can get locally often. I think C3s you can get locally. I will tell you though, factor B autoantibodies, the French group has published that can help you find the post-infectious patient. So for instance, if your patient is, every time they get an infection, their factor B autoantibody goes up. When they're done with their infection, the B autoantibody goes down. That's classic for post-infectious GN, but it's not quite at the level of being diagnostic, if you will. So maybe if I can summarize by saying, I didn't get to the transplant slides, but you know, we have developed a scoring system that if you have 3 abnormal biomarkers, so you have a nephritic factor, you have a really low C3, and you have a BB, for instance, we can tell you with 100% certainty, with 85% sensitivity, who's going to recur. Once we get to the point where that's going to be valuable for you, that's not published yet, you'll need to wait on us for that, then maybe you'll want more biomarkers, but right now they're not part of the diagnostic pathway. They are, for us, a way of telling how aggressive your disease is. For instance, if your nephritic factor is 4+, this is a patient that isn't going to remit easily for you on mycophenolate mofetil and steroids, for instance. But I still have to be fair to you by saying there's a lot we don't know about the biomarkers yet. We're going to find out a lot more once we can use AP blockade and figure out which biomarker signal tells us who's a responder and who's not a responder. Those 2 patients I gave you that were, I would call those home runs, I mean, you know, in any clinical trial, there's patients that don't respond. So there are patients in all clinical trials that don't respond. Those 2 I offered to you were home runs. We predicted they were going to be based on their biomarkers, number 1, but particularly because the really low C3 patients seem to be the responders. That's just an example.
Thank you. Todd, you had a follow-up question?
Next question, I guess. Do you think there's a role for anti-inflammatory or immunosuppressive treatment early in the disease course? You mentioned, you know, this is kind of a chronic disease where you might go from more of an inflammatory picture down to one that's purely C3 driven. Do you think there is any role for some corticosteroid or an anti-B cell therapy right up front at the time of diagnosis? I know we don't have any trial evidence for that.
Yeah, I think partially because I do quite a bit of pediatrics, there's always in the very beginning going to be a role for steroids, I think, because right after you get that biopsy, very many people are going to want to pulse just to start cutting the inflammation down and then put them on some course of steroids. I'm a big fan, though, of not long-term courses of steroids because in order to keep the inflammation down, you would need to have long-term course of steroids. This is more or less like that rheumatologic disease, right? That doesn't go away, and it's inflammatory its entire lifespan, essentially. It's just how much inflammation is it? But anyway, I think there probably always will be a role for some steroids. It depends on how fast we can do something different. I thought you were going to ask me about the SGLT2s and the sparsentan's, et cetera. I also think there's a role for them because many of these patients have CKD. And we know those agents are good for CKD. So we just have to figure out how to sequence that. Are we going to start them first or parallel, or how are we going to start them? I'm not sure exactly. I would love it if there were a clinical trial. We're not going to get one that's going to answer that exactly, but we'll get some real world experience, I think. Then I will say about I think you mentioned, did you mention B cell therapy? Yeah. So historically, and the published literature is not great on this, that targeting the B cells has not been great. For instance, targeting with rituximab or some of these other agents has not reduced the nephritic factors. Plasma exchange does. You just can't keep up enough plasma exchange to keep them down, to keep the nephritic factors down, right? So that's a long-winded way of saying is I'm not a big fan of B cell targeted therapy necessarily yet, but what if APRIL and BAFF drugs turn out to be just the ticket for the, getting rid of those nephritic factors? I would love to see that. But again, we're a ways away from that, not only because we need it to be proven in other diseases, but also we need to know what that safety is. And we know, we need to know whether it's going to target those nephritic factor making B cells.
Awesome. We are at time, but are you okay to continue?
Absolutely. I've secured the time for you. It's fine.
Awesome. David, did you have before? I'm sure Todd has more questions, but there's a hand up in the conference room if we can flip there.
Yeah, sorry. Another question. Again, kind of along the lines of biomarkers, and you might not have the answer to this, but your 0.6 of the many questions is probably one big one for me. It's how long do we use this? Because these are often very young patients that get this diagnosis, and they're looking at potentially being on this, like you, I think it's a chronic disease. It's not just going to go away. And so how, you might not have a sense, but do you foresee maybe what's going to come up for other than just proteinuria of something that might help guide us in when do we dial back after, after 5 years or what, and they're doing well, things are stable. At what point are we going to be considering to dial back, and what's going to help us to make that decision?
Yeah, you're right. We don't have the answer, and I don't think we'll get a trial to tell us that. So it'll be your experience over time that will tell you that. But what the preliminary thoughts are, for instance, if you have a pathogenic C3 gene variant, it's possible you're looking at longer term therapy in that individual with breaks if they want to try to get pregnant, or if there is an intercurrent infection, or. But if they're high-grade nephritic factors don't go away quickly, but let's say you find an opportunity, because, again, I'm biased. I believe that there really are drivers of disease, nephritic factors, pathogenic gene variants. If you could get rid of the nephritic factor somehow, some way, with a B cell therapy, or with let's just say some way, I think that's a time when you might consider backing up, right? Of course, you're going to want to be able to start it again very quickly if, all of a sudden we find out that that wasn't the only driver of disease. But I think that's part of what you're going to think about also. In my experience, people don't get over their C3G in a matter of months or even a short number of years. You may be aware that you've had patients that went on dialysis and that for unclear, for any number of reasons, they stayed on dialysis for a very long period of time instead of getting transplanted quickly. This has happened to me. They do seem to burn out their C3G. If you go into transplant with a burned out C3G, and I'm not recommending that we stop all these patients from getting transplanted, but it is my anecdote that if you have a patient with burned out C3G, they don't seem to recur as readily. So I do have some thought that there may be patients that do approach a time in their lives when they don't need complement inhibition. I just don't know yet how to tell who that is.
Thank you. Sounds like we need better access to those complement pathway testing. We probably need to have you on speed dial or some kind of fast track for our
Well,
testing.
I'm happy to talk with you outside of this if you'd like, because I'm happy to share with you. I don't want to be unfair to you because it's unpublished, but again, if we say, like, if we do 9 different biomarkers and 3 of them are abnormal, and again, I'm excluding BA, I'm excluding factor D, I'm excluding C3C because we happen to be using C3, so we don't want to double up on biomarkers. But if we have 3 of them in the abnormal range, we can predict. And we discovered that a couple of years ago, and then we've been testing it in our own patients. We have been able to predict who's going to recur. That's number 1. Number 2, we have 2 patients that have not recurred yet that we predicted would, but they have recurred histologically. So they have 0 clinical findings. So, of course, now we're leaping to, are we making a mistake by not treating histology? We don't know. They've only been recurred, if you will, for one's 1.5 years, one's been 2 years and 2 months or something. We don't know yet whether they have a shortened allograft half-life with just histologic recurrence. If you buy the Columbia data, they will have a shortened allograft half-life, but we don't have data to prove that yet in our group. But that's one of the things the transplant doctors are going to have to address. Are we going to, upon histologic recurrence, are we going to do a trial of complement inhibition, see if we can clean the histology up, like that rat model, for instance? If we can clean the histology up, then maybe we have improved the allograft half-life. But again, given how long an allograft should last, we're going to need years, to really answer that question.
Yeah, it's a tough question for sure now. Hey, thank you so much, Dr. Nester. I really, really appreciate this.
Absolutely.
Thank you. I think, again, tell me when you have to go, because I'm sure there will be questions. So Todd has his hand up again.
Yes.
I think you've maybe half answered that with your last question. So regarding the KDIGO guidelines, and I have a small cohort of patients that fit this kind of picture where, they are asymptomatic, they have proteinuria less than 1 gram. Most of them have transitioned from the pediatric clinic to the adult clinic now. And but they have a persistently low C3. Their GFR looks normal. with the I guess the tools that we have, we don't have great immunosuppression for them, and we don't have access to the complement blockade. I worry that this population is going to progress over 10 years, like you're telling me. And these young patients, they can hide kidney damage very easily. Their GFRs are normal, and you biopsy them, and they've got 50% glomerulosclerosis, and it's progressing. Are you still following that KDIGO guideline that, if they are low proteinuria, just to monitor, or are you trying to get your patients on therapy?
Yeah, again, it's been tough because I've had to find a clinical trial that would accept them, or if they're extreme enough, here in the United States, we can use compassionate therapy. So I do have probably, maybe 10 patients on compassionate because they didn't qualify for a trial. But I think you're exactly right. Children are incredibly good about hyperfiltering, so they can keep that creatinine in a good zone for a very long period of time until they suddenly don't, right? But I think you've hit on the most important piece. You've got a really low C3, so that's consistent with the animal model, right? You've got high suggestion that you've got a dysregulated complement system. So you biopsy them the first time, that's your diagnosis. You biopsy them again, and if they are progressive, I don't care what their urine protein is. I think we need to move forward. Now, that's my opinion. I'm not sure that my FDA will agree with my thought, but meaning I don't know what the label is going to come out that the patient must have 1 gram before I can move forward. I also hope, obviously, the label comes out without saying it must be native. You know what I mean? I'm hoping we can gain the real world experience based on our glomerular disease training that, this disease is progressive. Just because it's not showing me a clinical marker, I want to treat that. And so I would treat it, but then you need to get the 3rd biopsy to confirm that you're doing any good, obviously. So I think that biopsies will play a little bit more of a role for us in understanding whether these subclinical patients need treatment and respond to treatment.
No,
Yeah,
no, that's perfect. That totally fits with my thinking as well. The last one, I guess, is just picking your brain again. The nephritic factors, I mean, these are kind of activating autoantibodies versus, many autoantibodies, which are inhibitory. And my understanding is that you need very little nephritic factor to actually activate. Whereas, if you remove or you reduce an inhibitory autoantibody by, 50, 75%, that's going to allow that clinical pathway to be active again. Whereas if you've got these activating clinical autoantibodies, it doesn't take a lot for them to actually, turn on this pathway, which is maybe one of the reasons why B-cell therapies have been so disappointing. And that, even if we remove a lot of that autoantibody, just a little bit left is enough to turn that on. Have you any thoughts on that hypothesis?
Yeah, you may very well be correct. I don't actually have scientific evidence in my setting to back that up, but you absolutely may be correct, because that's what wouldn't shock me that that's the case. I will also add to that by saying even the autoantibodies are quite heterogeneous, meaning one patient's autoantibody binds very tightly and activates the complement system very tightly, but then falls off easily. Another antibody binds very tightly and really stays there for a long period of time. So you can see that that's the antibody that's exactly like what you said, because one antibody binds and stays there for a really long period of time. That's the really destructive one, as opposed to the other one that binds and falls off very quickly, if that makes sense. And in fact, in the laboratory setting, we use surface plasmon resonance, or SPR. Normally, your convertase in a normal individual should only be functional for about 90 seconds. If you need more, you make more. But in 90 seconds, it falls apart because of factor H, for instance. Someone with a nephritic factor, that 8-year-old I told you that she presented in October and was at end stage by early the following year, her autoantibody stabilized that convertase for 211 minutes. in the laboratory setting. And that may not sound like very much, but if you're supposed to be stabilizing the convertase for 90 seconds and you do it for 211 minutes, no wonder she didn't have any C3 left in her body. So that would be C3 that would, or an autoantibody that would be very aggressive and would be one that it wouldn't make any difference what the titer was. That one was going to be a bad player, if you will.
Yeah, no, and that just highlights too how difficult it is to measure these. Like, it's not a simple ELISA, right? It's a functional assay, and you need a lab that has really good experience, which I think is one of the reasons why, you know, Iowa is so good at it. But it's, you know, we don't have a single lab in Canada right now that's measuring nephritic factors, just because it takes experience, and it's not something that you,
Yeah, it's a very finicky assay in terms of, you know, obviously your person can't be the kids you just hired last week sort of thing. You know what I mean? It has to be people that are experienced in the lab, can work with sheep red blood cells and understand, you know, following a specific recipe, et cetera, et cetera. So it's difficult. And plus, even here in the United States, you find that some people, we use only immune globulins. So we know this is an autoantibody, right? There are places in the United States that do their nephritic factors with serum. And that may not seem like a big deal to you, but how do you know it's an immune globulin? It could be something else in the serum that's causing your positivity, for instance. So even standardizing it across labs, even here in the United States, is not completely perfect yet. It will be, I hope, you know, this happened a little bit with atypical aHUS and when eculizumab became available. Once we got eculizumab or terminal complement blockade, we kind of stopped studying atypical aHUS. And that's not good. You know, and I get why we did, because we had such an amazing response to this drug, right? But it did slow science down as far as I'm concerned. I am hoping that getting access to AP blockade doesn't slow the science down, because you guys have brought up, and I listed a whole, there's lots of questions that we still need to answer. So I'm hoping that the science still moves forward. I know in our lab at Will, we you know, we continue to think about what we need to understand better, you know. We're not there yet. I mean, it's going to be amazing if we get AP blockade in the near future, but we still, the heterogeneity of disease, like why do these young people, what I thought you were going to tell me about the low C3 in the young people, Matthew Pickering, I don't know if you know who he is, but he's actually a rheumatologist in the UK, but he sees lots and lots of C3G patients. He tells me all the time about, he has had for the longest time a young lady that presented to him at 18, undetectable C3, just barely urine protein. He's followed her for years and years and years, and she's done nothing. She hasn't gotten more urine protein. She hasn't lost kidney function. Now, she could be, you know, the hyperfiltering young patient, but what is that? How can we tell the difference between that individual and my 8-year-old that went to end stage within 6 months? You know, I mean, we have to be able to figure out who that is, because that's going to help you figure out who you need. You know, don't wait. You know, you need to start your complement inhibitor now. Yes, you can do your pulse, and yes, you can do your parallel ACE or ARB or whatever, but don't delay, you know, an AP blocker in that patient. But we got to figure out who that is. Unfortunately, it's a lot of patients. We just don't know how to figure out exactly who they are.
Thank you. So thank you again for that stellar overview and staying on, you know, a quarter hour past to answer our Q&A. I'm sure we could have another hour of questions here, but we'll let you go. And thanks again for that wonderful talk.
Very good. Thank you. Take care and have a good day.
You too.